Thank you very much. I will try to improve the comments that you have already given me. And please subscribe and share it, like it, comment it before you start to watching this video. We have seen on previous lecture series in the part 2 on stroke. We have seen that important clinical symptoms and the diagnostic approach of stroke, and we have seen also important differential diagnosis that we should think of in our mind when we are thinking of about the diagnosis of stroke. Okay, in this part 3 lecture series, we will try to cover uh, mostly the management parts of stroke, both how to manage the ischemic stroke and how we manage the hemorrhagic stroke. So with this, initially, whether the patient has, before we classify the patient as has hemorrhagic or ischemic stroke, initially in the emergency department, immediately after we have seen the patient, after patient presented to emergency room, we generally for any patient with a stroke, you have to check airway, breathing, and the circulation. If the patient is comatose, if the patient vital signs are deranged, you have to check for the airways and the breathing and the circulation, because one of these things might be affected, and you have to put the patient on oxygen, and IV access is also important, and you have to monitor the vital signs. And the other important thing immediately that you have to check is blood glucose level, because these patients, they might be either hypoglycemic or hyperglycemic. So patients might have undiagnosed diabetes. Possibly they might present with high blood glucose level, or patient might present with long duration of with no meal, long duration of fasting, so that they might present with hypoglycemia. So you have to check initially the blood glucose level. So that is for all patients presenting to emergency with symptoms suggesting of stroke. You have to do all these things. The other thing is then based on the type of stroke, your management approach is different. So before starting management for ischemic stroke and hemorrhagic stroke, that it is important you have to differentiate. Really, you have to identify whether this patient has ischemic type or hemorrhagic type stroke, because the managements are totally different for hemorrhagic and ischemic stroke. So for differentiation, you need to do brain CT scan. As we mentioned in our previous lecture, non-contrast brain CT scan, non-contrast enhanced brain CT scan is the first line of investigation modality for a patient in whom you are suspecting of stroke. So if the CT result comes and says that the patient has ischemic stroke, you have to start management for ischemic stroke. For a patient to present within 4.5 hours, IV thrombolysis is indicated. Tissue plasminogen IV thrombolysis is indicated for patients who present within 4.5 hours of the onset of symptom. So IV thrombolysis is indicated for ischemic stroke. The other thing is mechanical thrombectomy if the patient present within 24 hours. In fact, this duration is not the best. The best time that is preferred is the patient presentation within less than 6 hours. Then mechanical thrombectomy is indicated, and that is the standard. But it is possible. It's possible to do a mechanical thrombectomy up to 24 hours if the patient presents within 24 hours of the onset of symptoms of the stroke. So with large vessel occlusion and anterior circulation, usually that's an important indication to do mechanical thrombectomy. So for the hemorrhagic stroke, if the CT result shows you the patient has hemorrhagic stroke, very important management is first you have to think about the blood pressure of the patient. Controlling the blood pressure is the mainstay of management for patients with hemorrhagic stroke. In fact, if the patient was on any anticoagulant, like warfarin or could be aspirin, clopidogrel, and other anticoagulants. You have to do reversal for that. You have to do stop anticoagulants, and you have to give a reversal for the anticoagulation. So any anticoagulant should be halted at that time until you manage the patient's acute condition. And in some selected group of patients, neurosurgical intervention might be indicated, like patients with mass effect. Patients with if the hemorrhage in the brain has a mass effect with cerebral herniation, especially bleeding in the cerebellum, with mass effect and brain herniation, that neurosurgical intervention is very important, and it has a good prognosis if immediate neurosurgical intervention is done. This group of patients has a good prognosis. So the other important thing we have to discuss here is about the management of the complication. So any patient with stroke might present with any complication like cerebral edema. Cerebral edema is most important complication of stroke. So you have to manage the cerebral edema. So it could be a hemorrhagic stroke, it could be ischemic stroke. So both types of stroke can present with signs of cerebral edema and increased intracranial pressure. So you have to manage the patient uh, about for the increased intracranial pressure. The other is seizure. Seizure could be one of the important complication. So important complication is seizure. So you have to manage the patient. If the patient has active seizure, you have to give short acting that can short-acting anticonvulsants, short-acting anticonvulsants that can control the seizure of the patient, and then you give long-acting anti-epileptic drugs like phenytoin, phenobarbital. You have to give these drugs to control the seizure. Seizure is very devastating because when there is a continuous seizure, there is continuous neuronal damage that may threaten the life of the patient. So, with presence of continuous seizure, it is a life-threatening condition. You have to control the seizure as early as possible. You can. The other thing is infection. So this group of patients are at risk of developing infection. They might develop uh, aspiration pneumonia. They might develop urinary tract infection because patients with stroke, they are bedridden. They are bedridden, so any kind of infection in this group of patients is possible. Especially if they have lost their consciousness. So pneumonia is very common, and also other infections are possible. So you have to think and screen for infection for in such group of patients. The other thing that you have to uh, consider is DVT prophylaxis. DVT prophylaxis because uh, patients with stroke for long period they remain bedridden, so they are at risk of developing deep vein thrombosis as well as pulmonary embolism. So to prevent this deep venous thrombosis as well as pulmonary embolism, you have to initiate initially deep venous thrombosis prophylaxis, as well as you have to encourage early ambulation and physiotherapy. Early ambulation and physiotherapy should be encouraged, and you have to advise the attendants of your patient to do bedside physiotherapy and ambulation as well. So that is very important practice to prevent DVT as well as pulmonary embolism, which might put the patient at risk of death. The other important part of management is start of antiplatelets and anticoagulants. These drugs are indicated for patients with with ischemic stroke. For patients who present with ischemic stroke, you usually start antiplatelets, and sometimes anticoagulants are also indicated. So antiplatelets like aspirin, clopidogrel for non-cardioembolic stroke, and anticoagulants are indicated for patients who present with stroke plus atrial fibrillation. You have to start anticoagulants like warfarin and other anticoagulant drugs. So the other important part of management for stroke patients is strict BP control, a strict blood pressure control, and glycemic control in diabetic patients. And you have to start statins for dyslipidemia and smoking cessation as well. In fact, statins should be started not for patients with dyslipidemia only, for any patient, who presented with ischemic stroke, you have to start statins like atorvastatin, somvastatin. You have to start. So statins are indicated uh, uh, this regardless of the patient has dyslipidemia or not. For any patient who present with ischemic stroke, you have to start statins. You have to start statins. And smoking is one of important risk factor for ischemic stroke. So you have to advise your patients to cease smoking. Smoking cessation is very important. And the other thing is glycemic control in diabetic patients. In fact, glycemic control is not only for diabetic patients. For non-diabetic patients, they might have stress-induced hyperglycemia or sometimes hypoglycemia also due to they might have altered mental status, they might not be feeding well, so they are at risk of also entering into hypoglycemia that increases the patient's risk of dying from neurologic damage, from neuronal damage. So both hypoglycemia and hyperglycemia is devastating for a patient with stroke. So glycemic control, you have to do random blood sugar, whether the patient is diabetic or not. You have to do random blood sugar every 6 hours. Every 6 hours, random blood sugar should be done for a patient who has stroke. The other very important we have to discuss is blood pressure control. So blood pressure control for hemorrhagic stroke patients, the blood pressure control, as we said, should be strict, and it is the main management, the mainstay of management. The goal of blood pressure for patients with hemorrhagic stroke, your goal is making the blood pressure less than 140 by 90. Less than 140 by 90 is your goal of blood pressure drop in patients with hemorrhagic stroke. For ischemic stroke, in during the acute presentation, for ischemic stroke during the acute presentation, you have to take care of not to significantly drop the blood pressure of the patient, unless the patient has a blood pressure of more than 180 by 110. You have to uh, you have to hold antihypertensives. You have to not start antihypertensives unless the patient's blood pressure is more than 180 by 110. Otherwise, for the first 72 hours, from the start of the symptoms, you have to keep the blood pressure of the patient higher level. Then, after 72 hours, you can manage the blood pressure of the patient as any patient with a chronic hypertension. Like your goal of blood pressure becomes less than 140 by 90 after 72 hours. Otherwise, within the first 72 hours for a patient with ischemic stroke, your blood pressure goal is not less than 140 by 90, it is higher. Okay, then the other important part of management for patients with stroke is lifestyle modification and rehabilitation. Diet, you have to advise your patient on dietary modifications, on exercise, and on alcohol moderation, and also patient education and follow-up. That's very important. You have to tell your patient about the follow-up importance and drug adherence, clinical adherence. That is very important for patients' lifelong existence. Alcohol, if they are very alcoholic, you have to tell your patient to decrease alcohol consumption. Diet is very important. So in current the today's world, the diet we eat is very risky for any cardiovascular disease. So you have to advise your patient on healthy diet and exercise as well. The final thing that we will discuss is about the stroke rehabilitation phase, because these patients usually, as we mentioned earlier, they remain for a long period of time bedridden. So You have to think of stroke rehabilitation acute phase within the first 7 days, most likely within the first week. They remain in the hospital. So especially you have to start in the hospital the physiotherapy. You have to advise well the attendants. You have to show the attendants how to do the physiotherapy and how to do the ambulation. That's very important. The first acute phase. Subacute phase, 1 week up to 6 months, and the chronic phase is beyond 6 months. And as we discussed previously, early mobilization is a key. That's a key for the patient's healthy state. And stroke management needs a multidisciplinary approach. It needs physicians, primary physicians, physicians who are trained on stroke, specialists as well, and subspecialists also might be needed. Physicians in general are needed. Nurses, they are very important. Nurses are very important for the patient's nursing care, to show the attendants about the physiotherapy, to tell about the diet and important things about the patient's dietary approach. So nurses are very important. Physiotherapists, as we said, there is a very important significance of physiotherapy. So involvement of physiotherapists and occupational therapists as well as speech therapists are also very important. So it is a multidisciplinary approach that the management of a stroke needs. Finally, the prognosis and the disability. The outcome of the stroke, in fact, depends on the type of stroke, whether it's hemorrhagic or ischemic stroke. Ischemic stroke, once it occurs, it's life-threatening, but after they recover from ischemic, I'm sorry, the hemorrhagic stroke, if it occurs, it is a life-threatening condition. But if the patient once recover from the condition, its outcome is usually the prognosis is very good. And the severity, the initial, for example, you can take ischemic stroke. If the infraction involved a large area of the brain, then the severity is high, so the risk of dying is very high. And the time where the patient starts the treatment also matters. And many patients usually remain with the residual disabilities. This is the case presentation. 65 years old male with right hemiplegia and aphasia, then history of hypertension and atrial fibrillation. CT shows left middle cerebral artery infarct, then